Right. Good afternoon, everyone. Welcome to NJSL Presents. My name is Luz Villarreal. I'm a reference librarian with the New Jersey State Library. I help present NJSL Presents here at the State Library. I'm very happy to introduce Victoria Pena Cardinelli, our speaker today. Victoria is a licensed clinical social worker with more than 20 years of practice experience in clinical social work. During her work at the Capital Institute for Neurosciences, Victoria pioneered the first outpatient social work services at Capital Health. Before joining Capital Health, Victoria worked as the director of child welfare services in New York City, where she helped develop, implement, and manage programs in the area of child abuse prevention. Okay. A few housekeeping items before we start. A reminder that you can submit any questions at any point during the presentation. You can do this using Zoom's Q&A function, or you can type your questions directly into the chat. When you exit the Zoom after the presentation, you'll be prompted to fill out a survey. Please do so. We really appreciate your feedback for future programming. We will be covering as many questions at the end of the presentation, to be clear. So any of the questions you submit during the presentation, we will get to them at the end. All right. I'm now going to very briefly go over your available Zoom controls as an audience. This is what your screen should look like right now. If you're on Mac or Windows, actually with the update, it might look a little bit different, hopefully not too different. If you're on a mobile device, it may look a little different, but everything will functionally be the same. In the left-hand corner, you'll have your audio settings. In the case that you're using a headset or earbuds, you can adjust those settings here. If you're having any issues during the session, please click the raise hand button in the center, and I'll do my best to help you with any issues, technical or otherwise, that are happening. On either side of the raise hand, you can either ask questions via the Q&A chat, the Q&A or the chat on the other side, because use either to submit questions, and then we'll cover them at the end as mentioned. I think that's it for housekeeping items. I'm very happy to turn it over to Victoria now.
Thank you very much, Luz. So I'm going to share my screen now. And I hope you let me know if it looks good.
It's looking good.
Perfect. All right. Welcome, everybody. My name is Victoria. I work at Capital Health. Thank you, Luz, for the introduction. I'm very happy to be here today to be able to have an opportunity to talk about suicide, to raise awareness about the prevention of suicide so that we can feel empowered to do something about it, and that maybe we can address those issues related to stigma, fear, about these topics. So thank you very much for being here today. I acknowledge it's not an easy topic. I acknowledge that maybe some of you that are in this webinar today might have been touched by suicide, maybe somebody you knew, maybe a family member, someone close to you, that may have had died by suicide or who has lost someone by suicide. So I know that it's not easy. So I wanted to just take a moment to invite you all to acknowledge what are your current thoughts, the current emotions that you associate with suicide right now, right here in this moment as we prepare for this webinar. So I know that I'm not asking you to share in the chat. It's very private, but I just want you to take a moment to acknowledge what are my feelings, what are my thoughts associated with suicide. And there is no right or wrong answer. It's a very personal subject. So in saying that, I'm hoping that at the end of the webinar, would ask you about the same and then see if anything changed as a result of the information that you get today. And that maybe we can empower ourselves to continue to raise awareness in our day-to-day lives. So I want to start the meeting by acknowledge the session by acknowledging that I don't have any disclosures. There are no financial interests or affiliations concerning the materials that I will discuss in this presentation. This is where I work. We have two offices, one in Bordentown, one in Newtown, at Capital Health. The numbers are the same. So if you have inquiries about services, behavioral health services with us, this will be the number. I know that you will have access to this PowerPoint presentation so that you will have access to these numbers. I would like to share the learning objectives. So we want to learn about suicide prevalence, so we can understand why is it that we're not alone. We want to raise awareness. We want to reduce the stigma. We want to learn about the different types of risk associated with suicide. We want to learn about the protective factors as well. They overlap, they interact with each other. We want to recognize what are the signs of suicide. We want to learn about the approaches in suicide prevention and what are some of the behavioral health interventions that can help minimize or address suicide thoughts, ideations, intents. And we want to obtain resources for support. So where do we go? Where do we call? Who are the people that can help us when in need? I wanted to start also by addressing myths on suicide. And a lot of the thoughts and feelings that maybe you identify having at the beginning of this webinar were associated to some of these myths, right? So I wanted to kind of clear out some myths, put those things out of the way. Sometimes we hear that suicide only affects individuals with a mental health condition. Well, the reality is that not everybody that dies by suicide has a diagnosed mental health condition. Sometimes people that attempt suicide or die by suicide do have mental illness, but it is not the rule. Sometimes situational, environmental stressors can lead someone to die by suicide. Once an individual is suicidal, he or she would always remain suicidal, or they would always remain suicidal, depending on how we identify ourselves. And the reality is that suicide or active suicidal ideation is usually a short term. It's short term, maybe situation related, so that if we're able to address the suicidal thoughts, the ideation, if we're able to identify those warning signs of suicide, maybe we're able to assist the person to ride that wave of emotion that feels like, suicide is my way out of this suffering. And then maybe at that point, we're able to, before the person acts into this impulse, we're able to provide an intervention that will provide the support where these thoughts, these ideations will again go down and they're not there anymore. So it is definitely something that can be prevented, that can be addressed, the suicidal thoughts that can go away. So most suicides happen suddenly without warning. That's another myth. Usually there are warning signs, and that's why it's important of us knowing what those are. They could be verbal, they could be behaviors, and they precede most suicides. Sometimes one common one is a suicidal note, something that people generally do, but we'll learn more about those before. People who die by suicide are selfish and take the easy way out. Sometimes we hear that too. Well, the reality is that typically people that die by suicide, it's not that they don't want to live. It's more that they want to end their suffering. And the way to ending the suffering is by addressing that sense of hopelessness and helplessness. So it's not about being selfish or trying to find the easy way out. And then talking about suicide is another myth will lead to and encourage suicide. Actually, the opposite. There is a stigma associated with suicide so that people are afraid to speak out. Talking about suicide is going to reduce the stigma and is going to allow individuals to seek help, rethink what their options are, share their stories with other people, mental health professionals, friends, family that can provide the support. So talking about suicide is actually a preventive factor for suicide. So we're talking about suicide, but so what is it? Let's find a definition of what we're talking about. And suicide is defined as death caused by self-directed injurious behavior with an intent to die as a result of the behavior. You may have found or know of people or have read or heard about people that do self-injury. So things such as cutting, or they do behaviors that are self-injurious. Those behaviors can be a high risk for future suicidal behavior. The difference between that and suicide is that this self-injurious behavior is done with the intention of causing death. So that's the major difference. We want to go over statistics now and incidents about suicide, because we want us to remember that we're not alone. You know, if you're experiencing thoughts of suicide, if anyone that you know is, they're not alone. Before I talk about the statistics, I wanted to acknowledge that September is Suicide Awareness Month. And, you know, before I was preparing for this talk, Luz was asking me, why September Suicide Awareness Month? And the reality is in my research is that suicide awareness was declared worldwide, globally, to be the month of September since 2003. So globally, September has been the month of suicide awareness since 2003. In the United States, we adopted September as the National Suicide Awareness Month in 2008. So there isn't a particular reason why. I think the reasoning behind adopting a month as to raise awareness about a topic is so that it is in our calendars, so that like any other reason why we keep notes and calendars is to make sure that we get some things done. So adopting September as that National Awareness Month is going to make sure that we're having these conversations, because maybe not putting it in the calendar would never have allowed us to have this webinar today. So that's really the reason why we have a national month for suicide. And I guess it's September because globally in the world, it has started to be that way since 2023. I'm sorry, since 2003. So yes, so we're not alone, and these are some of the incidents. Suicide is the 11th leading cause of death in the United States. It claims more than close to 50,000 lives annually in the United States, nearly 1 million lives across the globe. Is the third leading cause of death among youth and young adults ages 15 to 24. Is the second leading cause of death for ages 25 through 34. Is the fourth leading cause of death for ages 35 through 44. And over 1/3 of people who died by suicide were 55 years of age or older. The percentage of suicide victims, and this is more a fact, who have diagnosable disorders is 90 to 95%. So it is that high because a lot of times when we get to the point of suicide, maybe there was a mental health disorder that was never really addressed, that went untreated, that led to this outcome. There are certain groups that are more at risk for suicide, that have a higher prevalence. And some of those groups is the LGBTQIA group. The CDC in 2020 found that LGBTQIA groups have a high percentage of suicidal ideation. So 46% seriously consider suicide, 40 were planning suicide, 23.4 had attempted suicide in previous years. And what they also found is that among people in this group, if they had experienced rejection by family, by friends, if they had experienced instances of discrimination, if they felt victimized, acts of violence against them, then the prevalence of suicide attempts was definitely higher. Other at-risk groups represent men. Men die by suicide more frequently than women. Men 65 and older have higher rates of any group in the country. That has also been seen to be true for male veterans older than 65. Those numbers are increasing. Firearm, this is also a fact, is the most common means of suicide in the US in more than half of the cases. And another statistic is perinatal depression or deaths from suicide after childbirth, with up to 20% of global postpartum deaths occurring because of suicide. So that's another area that is closely being researched and where a lot of prevention initiatives are taking place right now. So we're going to start talking about the risk factors. And I was beginning to, at the beginning of the talk, we were talking about how suicide doesn't really happen for one particular case. Usually there is a dynamic interaction between risk factors and protecting factors. And suicide occurs in response to those multiple biological, psychological, interpersonal, environmental, social influences that interact with one another over time. So individual risk factors. Some of the individual risk factors are very well known, and it doesn't mean that just because there is a previous history of suicide attempt is not the one indicator that is going to say that this person will die by suicide in the future. That's not the case. These are just risk factors that can be addressed if we have awareness of them. Another factor is a history of depression or other mental illness. Yes, it is an individual risk factor that, if addressed, can also become a protecting factor. And we're going to see that when we start looking at protecting factors. Things can begin to look repetitive, but it is because there is a correlation. And if we do otherwise, then we can establish protection. Serious illness, such as chronic pain, is known to be a risk factor. Chronic pain brings a lot of suffering to people. And when there is a chronic pain that, is not going away and is affecting all areas of life, it becomes a high risk factor. Criminal legal problems, incarceration, job, financial problems are also known to bring a lot of high levels of stress. Impulsive or aggressive tendencies, if we don't have a good sense of impulse control, of tolerance for distress, that could be an indicator. Substance use has been identified as a major predictor of suicidal behavior, and the odds for suicide increase amongst substance users. It may increase also the impulsive and the aggressive tendencies that may be already present in an individual, then it makes the risk even higher. If there is a current or prior history of adverse childhood experiences are identified as potentially traumatic events that occur in childhood being defined anywhere between the ages of 0 to 17 years of age. That includes having a family member that attempted suicide or that died by suicide. Could be considered an adverse childhood experience. And also, when the word current, an adverse experience, it doesn't have to be in childhood. So having someone close to you that died by suicide, that attempted suicide, can be a risk factor in combination with other things. A sense of hopelessness, there is no way out to my suffering, violence, victimization, and perpetration. So I am in the cycle of violence. I'm suffering. don't see a way out. Again, sense of hopelessness. So these are individual risk factors, and there may be other factors that are not included here, but research has identified these as main factors. Risk factors in relationships. Risk factors in relationships are hurtful experiences that contribute to risk when we relate to each other. A family history of violence, abuse, neglect. Parental separations are often associated with increased suicide risk, as well as harming behaviors. It is also known that women experiencing turbulent relationships are also at increased risk for suicide, especially when the relationship is characterized by domestic violence, and in cases where the partner is exhibiting addiction, coercion, physical assault, jealousy, infidelity, threatening violence. So these are all relationship factors, bullying, relationship factors in school settings, in community settings. Sometimes bullying even occurs in our own home. The loss of a relationship, all those things leading to social isolation, deciding to not relate anymore, deciding to stay in because being out, being in a relationship with others is just way too dangerous. So leading to social isolation that can actually then become a risk factor for suicide. Community risk factors, lack of access to healthcare. So in our communities, we face a lot of health disparities. Health disparities pretty much are groups of people who have been systemically disadvantaged, who experience greater obstacles to health and support networks based on race, religion, economic status or socioeconomic status, sexual orientation, race, religion. So lack of access to healthcare is definitely a risk factor that is important, and that as a society, we have heard we're trying to address. Suicide cluster in the community, when there is a, in the schools, for example, someone dies by suicide, it communicates a message of this may be something that may be accessible to me as well. People may begin to consider that it's a way to address your suffering. So it's a risk factor. A stress of acculturation, right? Adjustment, acculturation, also referring to adjustment issues, changes, adjusting to change, whether it's acculturation or any other changes in our environment, is a high level of distress, and it can become a risk factor. Community violence, historical trauma based on histories of oppression, histories of inequality, and that limits our community access through innate beliefs about accessibility. So if we have a community history of trauma, if we come from communities that have been traumatized by discrimination, then that also has an impact on our own beliefs about our own ability to access and receive the services and the help that we need. Discrimination, I mentioned that already. Bullying. Bullying can affect any child or adolescent, and is a challenging problem not only for parents, families, but also for educators. Cyberbullying is a large and greater issue in recent years due to social networking and applications that will influence the adolescent's behavior in those settings. So bullying is as well a big community factor. Social risk factors, the stigma associated with help seeking and mental illness. Most people who seek and receive psychological help, they tend to experience shame, feel stigmatized after receiving the help. A stigma is defined as behaviors that are often perceived by the general public to be disgraceful or shameful, something to be ashamed of. So we don't seek help because of that stigma. And then it becomes a risk factor. Easy access to lethal means, yes, if we have the means, that if the access for those means is there, is going to make that risk factor even higher. Access to firearms in the home is one of the strongest predictors for suicide, and it is definitely one of the most lethal methods. Other things, such as overdose on certain prescription medications, are also means for suicide. So in these type of situations, knowing again the risk factors, knowing the warning signs can help us create plans for safety where those means can be taken away from people and decrease the success in that possibility, in that thought of dying by suicide. Unsafe media portrayals of suicide. We were talking about cyberbullying. We were talking about kids and young adults, even access to these platforms, where sometimes they portray suicide as something that is okay, or maybe even self-harm behaviors, something that you just do to release the stress or anxiety. And as I mentioned before, those type of self-injurious behaviors, they're not intended to call for us to die. But if we start to engage in those behaviors, the risk is enhanced. So it becomes those unsafe media portrayals of suicide. It becomes a real issue because these messages can be internalized. And if we're not talking about it, in addition to being exposed to this type of messages, then we're adding, these risk factors kind of build up on top of each other. So I hope that you're seeing all of the correlation now and how one thing doesn't really stand alone, including the economic factors. So if the economic factors are also present, in addition to bullying, in addition to access to portrayals of suicide in the media that are not helpful, right? Unsupportive environment at home. So when you add all of these things is when those risk factors really, really become problem solve. So not everything is bad. And as I was telling you, those risk factors then lead us to think that, okay, we know these things. So what can we do about it? And then we can only hope that we can embrace the possibilities to be empowered to do something about these risk factors, which can bring some hope. And those protecting factors really start with us, start at the individual level. So we have more control that we actually think we have, which is nice to know. And this is kind of a big diagram that I chose to utilize in an article that I read about efforts being made to address risk factors. So global communities are trying to understand what are the things that we can do at the individual, relationship, community, society levels to address the risk factors and to enhance people's well-being at all these levels. So if you think about it, if individually we begin to think about ways in which we can grow to be more resilient, where we can begin to connect more to other people, when we can maybe get the help that we need, see a psychiatrist, see a psychotherapist, maybe get help for substance abuse, and we are able to break those cycles of abuse that maybe we lived through when we were children, and we want to prevent further abuse in our own homes, right? All those individual factors of wellness are going to impact the way that we relate to other people, so that those relationship factors, risk factors, can then be addressed. Because if we are better able to cope with our emotions, if we are more prepared to deal with the stuff, that life brings to us, by building ourselves up, by building our support systems up, then our relationships with other people probably will be enhanced. And then if our relationships with other people are enhanced, then our sense of community and support is also enhanced, right? We are maybe able to collaborate better with the school district with our children are in. We can empower our children to engage in communities of support, sports, religious or groups, like, the churches that we belong to. Anything that you believe is part of what is important to you and part of your values. And then we're hopefully able to then have a better relationship with our society as a whole, right? And the society aspect of it is something that is greater than us, right? So this is where our government, local officials, we're trying to develop policies that can enhance the economic stability of people, so that people can grow, so that people can get access to healthcare, education, basic needs. So everything really interacts with one another. So this big picture was pretty much to show that relationship. And we're going to now begin to look about these individual protecting factors on a more tangible basis. So social and emotional competence talks about the person ability to interact within one's social and community, knowing that you're able to self-regulate your emotions, that you're able to find wisdom when faced with challenging situations. And this refers to problem-solving skills, conflict resolution skills that are important that we work on getting better at. Resilient temperament, all these skills, conflict resolution, distress tolerance will help us become more resilient, meaning we can bounce back from difficult situations. We can recover, because the difficult situations we might not be able to prevent or control, but how we respond to them talks about, and how we recover from them talks about our resilience. Belief in society rules, believe it or not, it's is a protecting factor, because if we're able to understand that there are things that are acceptable, there are things that are not, there are things that are good for us, there are things that are not, and we're able to believe and abide by those differences, it's a protecting factor. Cultural and religious beliefs that discourage suicide and support self-preservation. A lot of people that are faced with suicidal thoughts, one of the questions is, what keeps you here? And a lot of times the answer is my religious beliefs, right? God will not forgive me if I was to take my life. It is not my choice. It is not, it's so is that it is a religious belief that it becomes a protecting factor. Sometimes people say the protecting factor is that it is not right, to take my life. It's the belief in that society is not the right thing to do, and I want to do the right thing. The skills in problem solving, conflict resolution, nonviolent ways of handling disputes. I was just referring to that when talking about resilient temperament, social and emotional competency, reasons for living. What keeps you here, right? Family, friends, pets. That's important for connection. Individual factors, being connected to people, being connected to things that motivate us, that help us move forward, is an important protecting factor. Positive academic performance in young adults, children. It's something that anchors people to the sense of confidence, that I'm good and I'm good enough. I'm doing well in this area, and it can enhance a person's willingness and ability to try, to continue to learn, to stay here. Attachment and commitment to school, like any other positive attachment, not only to school, but also any other positive attachment. Sometimes when we live in environments where there is a lot of discord, environments when there aren't many possibilities, but we have one particular safe attachment, someone, something that means a lot to us, that really got to us. Sometimes that person, that thing, that community will make the difference between wanting to get through this moment to not. So those attachments, safe attachments, secure attachments, are a great protecting factor. Perceive norms regarding drugs use and violence, right? So drug use, we talk about as being a big risk factor that can enhance the risk for suicide. So if we have norms that believe that advise us against the use of drugs, against the use of violence, is definitely a protective factor. But again, we need to be able to teach our children then what is the alternative. So that's when we talk about social emotional competency. How can we foster resiliency in our homes, right? So again, interacting with one another. Relationship protective factors, support from partners, friends, and family, that connection, feeling that sense of connection, those attachments that we were just talking about. Family management practices, frequently monitoring and consistent supervision. Believe it or not, children want the discipline. Children want the structure. Even if they roll their eyes, even if they think we're annoying, the reality is that when we are in connection with the lives of our children, of our adolescents, with our young adults, even, when we have communication, then it's going to be helpful. It's going to be a protective factor, because if those warning signs maybe begin to come to the surface, you are going to be aware. You are going to know. And that represents a possibility. Discipline practice, same thing. Just the act of building a structure and guidance and support. Community protecting factors refer to the access to those programs that provide support. So ongoing medical and mental health care, right? Our primary care providers, hopefully we all have access to one. If we don't, there is access, even if there is no insurance. We just need to look for that connection to a healthcare provider, that we can talk about behavioral healthcare needs, that can guide us to see a healthcare professional, so that you can get the support that you need to address any depression, any anxiety, any issues with emotion, or psychosocial distress. Social organizations such that links people to community members, for older adults, senior centers, for example, those are great opportunities for interaction. So encouraging our seniors to get involved, to engage in activities, to talk to others. The capacity to solve community problems and attachment to community, like we're talking about the attachment to school, right? A positive attachment to that. So engaging with programs, with organizations that maybe volunteer, to provide services to others. It enhances our sense of capacity, of confidence, of wellness when we're able to engage at that level. Having access to safe and secure living environments is definitely a protecting factor, that when we're not in a safe and secure living environment, and we know that, being able to access the resources that can give us the possibility to find that environment where we feel more at ease is also key. So if we know that our environment is not safe, is not secure, knowing that and then finding the resources so that we can provide that environment for our children. In that environment really is, again, talking about relationships, individual factors, then that's a different kind of risk factor to be addressed. But it can become protective factor if we do something about it. Society protecting factors reduce access to lethal means of suicide, right? So laws that will limit people access to guns, cultural, religious, or moral objections to suicide is a society protecting factor. We talked about that. Financial security, we also talked about that as a risk factor. So finding a way where we can feel that our basic needs are being met and that we have access to jobs and housing is definitely a protecting factor. If not there, accessing the resources, it is definitely important. So we may come in contact with someone that is not doing well. A friend, a coworker, family member, maybe you know someone that knows someone that maybe is not doing well, severely depressed, behavior is changing, the way they're talking is changing. How do we know suicide is something that could be in the mind of this person? So research came up with an acronym to remember the warning signs for suicide. And the acronym is path warm. Nothing related to suicide, but it's just a phrase that would allow us to remember that I is for ideation. So are there threats or talk or of a wish to hurt or kill oneself? So ideation is when you hear the person talking about the wish to hurt themselves. If there is substance abuse, is there increase in alcohol use, of alcohol, drug abuse? Is there an increase all of a sudden? They express no reason for living. There is no purpose. There is anxiety, agitation, restlessness. They're not sleeping. They feel trapped, feeling that there is no way out. There is hopelessness. There is lack of self-value. That's what we're talking about, those activities that can enhance our sense of wellness, of confidence. So hopelessness is that lack of value to others don't care for me. The future is unchanging. Withdrawing from friends, from family, sleeping all the time. Anger, uncontrolled and excessive expressions of anger. Acting recklessly, high-risk behaviors, dramatic shifts from typical mood states. So this is path warm. Ideation, substance abuse, purposelessness, anxiety, feeling trapped, hopelessness, withdrawal, anger, recklessness, mood changes. And these are just the identified symptoms or behaviors or expressions that can look in many different ways. So just knowing these signs is important. The good news is that we can prevent that through comprehensive approaches to suicide prevention. We want to recognize the warning signs, and then connect people to appropriate resources for care. We want for people to remember that there is hope and that people with mental health problems can get better and then may even recover completely. Self-management of mental health needs is possible. Seek effective care and treatment. Treatment should focus on suicide risk when the risk is there and underlying mental health and substance use disorders. We want to be mindful of transitions in different levels of care so that if we know we have a family member who's went inpatient, let's say in the hospital because there was intent to die by suicide, intent to take their lives, and they come out of the hospital, well, getting involved. What are the plans for transition? Where is it that you're going after your hospitalization? Do you have a psychiatry in place? Do you have a therapist? Right? So that those interventions then don't fall through the cracks, but that we can continue that momentum going. Responding to crisis, mobile crisis teams, walk-in clinics, hospital ERs, Peer-based crisis services, they're all there to respond to crisis situations. Reduce access to means, we talked about that. Life skills and resiliences. So building these skills, building resilience, critical thinking. How do we manage stress? Conflict resolution. Connecting to people, building positive attachments. These are all comprehensive approaches. So what if you come to someone who you feel they may be at risk? Well, we're going to have that honest conversation. That will be helpful. Talk to them in private. Just listen. Listen to their story. Let them know that you care about them. Ask directly if they're thinking about suicide. And I know this is probably the hard part. How do we do that, right? If we reduce the stigma of the myths associated, well, if I say it, they may actually do it. We might be more willing to ask directly, are you thinking about taking your life? Encourage them to seek treatment. Or if they already have someone that they're connected to, contact your doctor, contact your therapist. Avoid debating with them the value of life, saying, oh, you shouldn't worry about that, giving advice, because at that point of that severity, it's probably not going to be helpful. It'd be more helpful just to be where they are at and validate them and support them in other ways, taking them seriously, right? If they're talking about it, maybe it's not just attention seeking. Sometimes we think, oh, maybe this person doesn't really mean it. Well, I think we need to lead, or we need to lean towards caution, being cautious and preventive. Stay with them and call or text 988, which is the Suicide and Crisis Lifeline. So if you're really concerned about their safety, listen to your gut. Listen to your gut feeling. Lead towards prevention, protection. Stay with them. They might want to go to a crisis center. They may go to the emergency room. They may be agreeable for you to drive them. Maybe you call a mobile crisis unit to come to the home of the person and do an assessment there. What are some of the behavioral health interventions? So there are brief interventions such as crisis management, which are specifically to address the high intensity of those risk periods. There are therapies, psychological therapies that will focus on behavior change and that will focus on managing suicidal thoughts. Some of them is cognitive behavioral therapy, suicide prevention specifically, and dialectical behavioral therapy. There are medications that requires a full psychiatric evaluation by an experienced psychiatrist or mental health professionals. There are some psych nurse practitioners that can be equally helpful to be considered as part of the treatment plan. There are medications that can help with suicidal thoughts and ideations. And then there are different levels of care to address this type of risk. So there are inpatient hospitalizations, there are partial hospitalizations, intensive outpatient programs, and regular outpatient programs. And the mental health provider then will lead you through those levels of care. So there is help, and I wanted to kind of give room for questions. So I'm just going to get through this quickly. National Suicide and Crisis line is 988. Can be more simple than that. So please just dial 988 or text them. These are the chats. I know that Luz is going to be feeding these links into the chats for people to have access to. There is a crisis text line. These are our local resources. Early intervention services through Catholic Charities will do walk-ins. They will take people as they walk in. You don't need an appointment. And they will take you whether you can pay or not, regardless of insurance. Mercer Mobile Crisis, if you live in PA, Bucks County Mobile Crisis. And then for children and adolescents, there is Perform Care, the mobile response and stabilization services in New Jersey. They're all 24/7. Children and adolescents crisis stabilization services. Treble Project offers crisis intervention and suicide prevention for LGBTQ youth. the veteran crisis line. Now you can dial 988 and press 1 to deal specific with veteran emergencies. The SAMSAM helpline, specifically if there are issues with substance abuse that you would like to get more help and support with. And then I like this link because it's an educational link about teen health. So if ever in doubt, should I be more concerned than I am about my teen's behavior? I'm not sure what to do. Teen health will guide you through what is something that is more high risk and what to do in the event that that is the case, or maybe to give you the peace of mind that you are in the right path. Now, I just want you to, again, as I started to ask you at the beginning of our workshop together, how are you feeling? Now I want you to take a step back and sort of take a moment to remember that there is help and that there is hope and that we have more control than we think we do. We need to continue to empower ourselves to fight the stigma associated with these topics, to face the fears, to ask the questions, to get the help that we need. And that those things that we need to address, this issue of suicide, are already there for us, and even internally are already there for us. And we need to give ourselves the opportunity to access them. So having that, take a deep breath for a minute. And I'm going to ask you again now that you think about suicide. In light of this conversation, what are some of the emotions and the thoughts that come to mind? And again, you don't have to share in the chat. This is for your own knowledge. And if nothing has changed, or if you notice that you have more questions than when you came with, that's okay, because now we know that we have the resources and the means to address those concerns. So empower yourself and take action towards getting the help and the support that you need, or getting your friends and family the support that they need. And then these are my references. There are probably more, but a whole gist of what I talk about here today comes from these resources. So that is my talk for today. I know that there may be some questions.
And looks like we have a few questions. Actually, one just came in. No, actually, that's a comment. Okay. Do other countries with better gun control than the US have lower rates of suicide?
That is a great question, but I'm not going to pretend that I have the statistics. I think that based on our statistics, most likely, I believe that yes, that will be the case based on our stats. The opposite, I will say is true. But again, I don't have the statistics in front of me, but it is a great point for research. And some of these websites that are in the PowerPoint would lead you to those answers.
Someone asked to put up the resources slide again on the last slide that you had.
I'm sorry, what was that again?
Someone asked to put up your bibliography again.
Oh, my bibliography, the resources. Okay. Okay, give me 1 second. We have to bring it back up. Is everybody going to get a copy of this?
Yes.
Okay.
So if somebody wants to look at it now, but they're also going to get a PDF version of this.
Okay, great. Oh,
there's some more questions. Okay.
Okay, go ahead. I'm trying to get the.
No worries.
Okay, go ahead.
Do the school districts hold assemblies to inform teens that there is help for them?
So school districts vary, but given the national approach on suicide prevention? Yes. And I think is a great question for your school district, because there is definitely intentional government policies, especially in the schools now, that will encourage that. So I think is definitely something to talk about your school district, because the school districts do differ. And I think if they are having these conversations with our children in the schools, it would be great for parents to know, so that parents can do a follow-up, dialogue with your child about how did it go? Tell me, what did you learn? Do you have any questions? So it's a great opportunity to kind of open those conversations and continue those conversations at home.
Mhm. That's a great answer. What is the single most important thing you can do when someone expresses to you that they want to take their own life?
If they're telling you that they want to take their own life, I believe that it is important for you to take them seriously and to offer to take them for evaluation to the nearest emergency room, or if they're home and they feel safer at home, to bring the mobile crisis unit home so that they can be evaluated at home. There are a lot of misconceptions as to what happens if we call someone. If I call 988, is the police going to show up in my house? Is this going to happen? The answer is no. When we call 988, they're going to be assessing the risk, the level of risk for the person at that moment. And then if the risk is such where they feel that they need to involve emergency services, they will. But if it's someone that you love, a friend, a family member, just always offer to call 988 so they can talk to someone about it. Driving to a mobile crisis, drive them to the nearest emergency room, and offer the support that they need at that time, not leaving them alone.
All right, it looks like we're at the end of our time. We did have one other question. What can psych nurses do? Are they qualified to give you a prescription or diagnosis?
Yes, they are. Psych nurses work under the umbrella of a psychiatrist, and they are completely qualified to do comprehensive psychiatric evaluations and prescribe psychotropic medications.
All right. Oh, that's great. It looks like that's all the questions that we have. Let me double check. Okay, so when you exit out, this is sort of the end of our presentation, but when you exit out, there will be a survey for all our audience to fill out. Please do that. Sorry, I'm looking for some notes. There it is. Okay. Yeah, that looks like all the questions. And then thanks to everyone who attended, and thanks to Victoria for a wonderful presentation. Very helpful, very informational, very important. Do you have any last minute remarks or information you'd like to share, Victoria?
No, I think I don't. I think I look forward to feedback, and if there is anything else that I can provide afterwards, I'll be happy to.
And we did put in someone is asking for your contact info. Would you like
So
to
it is
provide?
in the slides.
Mhm.
The number in the slides is 609-689-5725.
See if I can find that somewhere. 56725, did you say?
It's 609-689-5725.
Mhm. And then, let's see. Mhm. Okay, I'll put the number in the chat very quickly. Okay. Okay, awesome. You've all been reminded of the survey. I believe that's everything. Thank you so much, Victoria.
Thank you.
So
Bye-bye.